click on the screen.
Okay. So I'll just start by asking how many of you have ever had a sore back, neck, shoulder, or knee? Put up your hands. Okay. Have anyone had an MRI or CT? An injection guided by an ultrasound? And a knee arthroscopy? Other surgery for those complaints? And okay, and how many of those do you think were really necessary? I hope that by the end of the talk, you'll be quite skeptical. So we know now, this is John Ioannidis, who's an amazing physician from Stanford. And he said that most developed countries are spending and wasting so much healthcare that healthcare has actually become one of the leading public dangers for health. It's probably now the environment or climate change, but we are contributing to the problem of poor health due to what doctors and other clinicians do. We know it's been estimated that about 60% of healthcare is actually low value. That means it doesn't benefit anybody. Another 10% is harmful. So that's 40% of what doctors do every day. This is an old study now, but the Institute of Medicine estimated $750 billion a year in the US was on unnecessary healthcare. And they tried to break it up, and some of it's fraud, some of it is excess admin costs, but where I've arrowed at the top, that's unnecessary services. So doing things that are totally unnecessary, that are of no benefit and might be harmful, and using higher, more expensive things when cheaper things might be just as good. In almost a decade now, I was involved in a Four Corners episode by Norman Swan, which was about this problem. And so it's already been nearly a decade that we've been jumping up and down about this problem of low value care. In Australia, the Financial Review estimated about $30 billion a year was on unnecessary care, and most of it was on new and improved services, as I'll show you. So the problem with this is not only is there no benefit from the people that are recipients of that care, but it wastes valuable resources for people who could benefit where it is necessary. And so they miss out. And not only that, but it can, if it's a high carbon problem, it also significantly affects the environment. And healthcare in Australia is responsible for 7% of our carbon footprint. So it's a sizable proportion, and that's the same as the whole of South Australia due to any, roads, everything. 7% is how much we are wasting in healthcare. A lot of it is because of gas. But it compares to the UK, which is 3%, and I think we're even higher than the US, actually. So this is the stuff that we're spending. So some of the increase in costs over time is just because we're aging and because the population is growing, but this whole maroon thing is the excess services. So the people are getting more health services and they're getting more expensive health services. And if you remember that 40% may be no benefit and or harmful. This isn't a new problem. Ivan Illich was really talked about it in 1976, and there have been many books on this problem since then. So that's already almost 50 years. And the medical journals have been talking about it for a while. There are too much healthcare series in the BMJ and places like JAMA, internal medicine. So it's not a new problem. And it matters, as I said, because it drains, it harms the people who receive unnecessary care. But it also makes us look bad. It drains our professionalism, and there are lots of flow-on effects from that. even the New Yorker has written about this avalanche of low-value care. And again, it's almost a decade ago that this article appeared. So there are many factors that contribute to this low-value system. One of the biggest problems is that medical care is based on a business model. So the more services you receive, the more profit that people make. And so that's like a perverse incentive to do more. We tend to treat rather than prevent illnesses. There's a lot of perverse incentives, so we reward the wrong care with our MBS, and we don't reward good care necessarily. I'm going to talk a little bit about new tests and treatments that are finding more and more abnormalities, but a lot of them won't harm anyone in their whole life, but we find them and then we act on them. The media has a role to play. They hype up miracle cures, and we have patients who have unrealistic expectations about what we can do. But for that, I blame us. We give them that unrealistic expectation that we can fix them. So we wrote the book really because we were interested, there's been books about the bad pharmaceutical industry and bad, device industries, but we wanted to focus on the clinicians and what is our role in this problem. So we wrote the book because of what I've just told you really. And we think that even though many doctors know about this, the public are largely unaware of this problem. So we wanted to raise awareness. We wanted to start conversations just like this. And we wanted to encourage people to be a little bit more skeptical. We didn't start out to disparage all doctors. Doctors try their best. Sometimes it's really not their fault, some of the things that they do. But we just want people to be a bit more skeptical and to ask questions. And I'll talk about that a little bit at the end. So the book is called Hippocrasy, and it is spelt how we wanted to spell it because it's actually based on the Hippocratic Oath. And Ian and I were on a walk in New Zealand thinking we wanted to write this book. And we suddenly thought we'd just look at the Hippocratic Oath, and we realised it was actually perfect for what we wanted to talk about. The pledges in the oath are as valid today as they were whenever they were written, even if Hippocrates himself didn't write it. And so the chapters are really about around the oath, except the first one. First, do no harm is not in the oath, but we wanted to do that as the first chapter. And I'll just give you a flavour of what the pledges are. So I will respect scientific gains, and I'm going to talk about beliefs in personal experience over actual science and evidence. The pledge actually talks about over-treatment, even back in 15th century. So I'm going to tell you about over-diagnosis and over-treatment. This is about the warmth and sympathy should outweigh the surgeon's knife. We need to be humble. We need to treat the person, not the test results. And we need to not medicalise normal. So people who are actually normal, we don't need to make diagnoses that won't help them. And we shouldn't be afraid of saying we don't know. And prevention is always better than having having to treat. So I'll go into a few of those things. So the first thing I want to talk about is that we often make superficial assumptions about what we're doing, and mostly we're wrong. We tend to overestimate the benefits of what we do and underestimate the harms. And I'm going to talk about each of these things. I'm not going to talk about defensive medicine, but one of the things that the doctors say they have to do tests because they don't want to be sued or they don't want to miss anything serious. And so it's always a tightrope between those things, but most things can wait, and you can delay doing tests and treatments and just wait. And doctors are increasingly finding it difficult to do nothing and saying, let's just wait, let's see what happens. And every other week I get letters from sports doctors and surgeons saying we have to do something. And even if they know what they're planning to do, doesn't actually work. And just because everything else has failed, it doesn't mean that something that's been proven not to work, like surgery, should be tried. If it doesn't work, it's not a natural progression for surgery if all else fails. That just is illogical. So why do we overestimate and underestimate? Well, we want to believe that we're helping, and we're more accepting of evidence that confirms our prior beliefs. And this is called confirmation bias. And we do it across all walks of life, not just medicine. When we don't know, we just assume it works so that we can do something. I think increasingly we know that doctors don't understand the evidence, and this is really a fundamental part of medicine. You can't be a good doctor unless you have basic science literacy skills, and those skills are called clinical epidemiology, which tells you how to read literature about treatments and diagnoses to help your patients. And if you don't understand that, if you don't have the skills, then you're bound not to be a good doctor. We have miracle thinking, just like the gambler, and we distort the probabilities. If we don't understand the evidence, then we're very easily led by peer leaders who may not be evidence-based, and they're wrong, and they lead us down the garden path. And I'll talk a little bit about the problem of introducing new treatments into standard of care before they've been properly evaluated, and how that harms patients. And of course, it's in our interest to feel valued, and it's also in the patient's interest to think that what we're doing is going to help them. So there's a bit of denial there as well. So I'm going to talk now firstly about a diagnosis. So ideally, a diagnosis identifies something that's abnormal. A label is given and a treatment is offered, and we assume that the diagnosis is accurate and correct according to the professional standards of the day, and it provides information about prognosis, or what that means is the outcome. You know, is it severe? Is it mild? What's going to happen? And we have to assume that a diagnosis will improve the outcomes for the patient. So that's a diagnosis. What about overdiagnosis? Well, overdiagnosis is when someone's labelled with a condition, they're diagnosed. The diagnosis is actually correct. So it's not a misdiagnosis or a wrong diagnosis. It's actually a correct diagnosis. But the problem is that making that diagnosis and everything that follows won't help the patient in the whole of their lifetime. And I'll give you some examples of that. So this is what I was talking about before, about over-testing, this tightrope between not missing something serious and doing too many tests. But it's clear that we're doing far too many tests, and particularly in my field of arthritis and musculoskeletal conditions. So there are several ways that overdiagnosis can occur. The first way is that we screen people who are normal or healthy, and we find cancer. So we find breast cancer, we find thyroid cancer, we find prostate cancer. And we know in Australia and elsewhere that we overdiagnose many breast cancers. The latest data is about 30%. So 30% of women who get diagnosed with breast cancer, the diagnosis will not harm them. They will not die from the disease. They'll die from something else. But once they're diagnosed, they get treatment, and the treatment can be harmful. So that's one example, and I'm going to show you the example from South Korea and what happened in their country. In my area, it's people who have minor symptoms like back pain or knee pain or shoulder pain and get unnecessary tests, and then the abnormality that's detected is assumed to be the problem, whereas it's probably just part of normal aging. It can also occur when we widen disease definitions, and I'll show you what's happened in Australia with gestational diabetes. We can also label risk factors for disease as diseases in their own right. So things like osteopenia, which is thin bones, and it's normal as we age for our bones to get thinner in both men and women, but we call it a disease and we treat it, we act on it. There's no evidence that treating that actually makes any difference and is harmful because there are side effects or risks from the treatments. And then we create new diseases. So sarcopenia basically means weak muscles. And again, it's a normal part of aging, but it now has an ICD code. And while some people might rightly want to treat it with strengthening and exercise, there are drug companies around the world trying to find drugs to market. And they'll market it for this disease in coming years. Even though it's not a disease, it's just part of aging. So this is South Korea. And what I want to show you is they instigated a screening program. So they were doing ultrasounds in thyroids for other reasons and finding lots of cancers. Often the radiographers were doing them on themselves, and they are all mainly young women, and they were finding cancers. And so they were really worried, and the country decided they'd instigate a screening program for the whole population. And what happened was that the red line is the incidence of this particular type of thyroid cancer, which is papillary thyroid cancer. And this is what happened to the incidence over time. So many people were diagnosed. And when you're diagnosed with thyroid cancer, you get your thyroid removed. There's a chance you'll paralyze your vocal cords. You're on lifelong thyroid replacement and sometimes parathyroid because they take them out as well. You have this scar across here. But look down the bottom, that green line, that green dotted line right down the bottom, that's the mortality over time. Their mortality did not change. So diagnosing those extra cancers made no difference to mortality in that country. And this went on, you can see, for quite a few years until the doctors finally said, we have to stop this. So they stopped it around here. That's the call to stop it. And you can see that it actually gradually went away again. So this is a very, good example or bad example of screening that caused harm. It didn't help anybody. It harmed thousands of people, often young women. And that's just one example, but it's happening for lots of the cancers that we screen for as well. Not all, but some of them. It happens because we have more sensitive tests. So we now have really sensitive tests to pick up heart attacks. A lot of those elevated tests won't be heart attacks. And we have MRI machines that are picking up smaller and smaller abnormalities like lung nodules, and in my area, pick up all sorts of changes that are actually normal for age. So in asymptomatic middle-aged people, you can get a tear in your rotator cuff that occurs in over 10% of people, and just wear and tear is about 40% in 50 to 60-year-olds. Similarly, it's much higher in the back. Nearly everybody has degenerative changes. And in the knee, it's really high as well. Most people will have wear and tear from about the age of 40. And mostly it's normal for age. But what happens is that we're doing many more tests than we used to. And so this is on the left is ultrasounds of the shoulder in primary care. You can see it's now costing almost $55 million, and the numbers have tripled, actually. And it's actually a useless test. So the utility of this test in primary care, general practice, is useless because you'll pick up these abnormalities, and if you're 80, you've got about a 90% chance of picking up something abnormal. And if you think that that's the cause of the patient's pain, then you'll refer them to a surgeon or whatever. We're also doing lots of heel and ankle ultrasounds, another completely useless test. I don't think I've ever ordered one in my whole life. And so this is part of the problem. For back pain, we're also doing a lot of imaging, and it's been shown that imaging increases the healthcare costs, increases the number of services that you get, increases the number of people that get surgery. increases absence for work, and there's no benefit. So there are really good trials where they've compared no imaging to imaging. At the end of a year, people are exactly the same, but the people that had imaging have had surgery. This is data, just recent data from Victoria, looking at the number of people that get imaging in primary care. So at least a quarter of people who go to the GP with back pain get some sort of image, about a third with neck pain, about 50% with shoulder pain, and about almost half with knee pain. And in shoulder pain, it leads to these shoulder image-guided steroid injections, which we've proven are no better than just injecting steroid blindly, or even just injecting it into your arm. Makes no difference. It's a systemic effect. So we're wasting billions on these image-guided injections, and GPs are now de-skilled. When I started, they could all inject. Now they don't even want to inject a knee. They don't know how, and they're not confident, and they send them to the radiologists who reap the benefits. It also, in workers' compensation, this is one of my PhD students showing that if you've had imaging, the time off work increases dramatically. So you can see 49 weeks if you've had more than one scan, versus 6 weeks if you've had no imaging at all. So we're harming people. They're not going back to work, and they think they're injured. And one of the reason for this is that both doctors and patients think that you can find the cause of back pain when you image, which is actually not true. Most back pain, you can't identify the cause. In about 95% of patients, we don't know why you've got back pain, but we know that most of them get better whatever you do. And here's the data to show that about 50% of patients think that they need imaging to find the right treatment. And we've done some qualitative studies, even I don't have a medical background, but I think I have a good enough understanding to know that you can't make assessments unless you've done imaging. So that's really not correct, but again, it's probably our fault, and a lot of the clinicians believe this as well. Furthermore, MRIs and CTs have a huge carbon footprint. So MRIs, it's like driving, one MRI is like driving a car 145 kilometres, CT a little bit less, and that's compared to X-rays and ultrasound. So we know we're doing far too many MRIs and CTs, so it's ruining the planet, and that's in turn affecting the health of other people. So gestational diabetes, this is what happened to gestational diabetes. They widened the criteria. So with the old criteria, about 1 in 20 women who are pregnant have gestational diabetes. And so they're at increased risk of fetal, big babies and then adverse effects. The criteria were widened so that now about 1 in 5 women in Australia who are pregnant will be diagnosed with gestational diabetes. So more women being diagnosed, they have more tests, they're more anxious. And there are now at least 2 trials to show that it makes absolutely no difference to their outcomes or their baby's outcomes. So we're over-diagnosing many more women. And there are now colleagues in Australia trying to reverse this widening of disease definitions, which come from a good place. They think they're helping people, but they don't think about these unintended consequences. So a lot of these ideas are good, but you have to think about the potential for harm, not just the potential for benefit. So over-treatment is like over-diagnosis. It's treatment that you receive that's totally unnecessary and doesn't actually improve your outcome. And again, it can occur from the same things, widening disease definitions, screening people, and it also includes things like futile treatment in people who are dying, and over-treatment in childbirth as well. And again, it's often driven by this perception that overestimates the benefits of what we do and underestimates the harms. So this is ultrasound guided injection. So you see an abnormality on an ultrasound, which is a useless test. Most of them are not the cause of the patient's pain, and they get sent off for ultrasound guided injections. So we're spending millions of dollars on this useless treatment. It's now over 500,000 people a year. Back pain I've already talked about, but we show an increased number of people getting spinal injections, which we now know don't work for back pain. They're useless. This is what happens. This is what spinal fusion. You don't get it in a public hospital because they're too busy treating things that need treatment. But in private, you can see what's happening. And this is getting worse and worse. And there's now good data to show that fusion makes no difference. You don't need fusion. It's a waste of time, but it increases the risk of harm. So knee osteoarthritis is another of our pets. So osteoarthritis occurs, as I said, really commonly, and it can involve the lining of the joint. It can also involve the cartilages or the menisci. And most people have changes, as I said before, over the age of 50. And it's common both in people with and without pain. So if you see a scan in someone with pain, doctors tend to wrongly assume that that's the cause of their symptoms. But when you look at them long term, most people, those changes are stable and they never have symptoms over time. But what we know is that meniscal tears increase also with age, and again, similar rates in people who have pain and people who don't. But arthroscopy's been around for a long time. We always thought you'd go in there, you'd clean out the joint, and that's how the surgeons would describe it. It sounds logical. You clean out the joint, so you give the knee another good 10 years. We now know that that's a bunch of rubbish. And in fact, not only is it not beneficial, we now know that it actually increases the rate of the progression of the arthritis. So it's actually harmful. And we know that it actually leads to joint replacement sooner. So now no one is doing, or no one should be doing arthroscopy for knee arthritis, which is good. But people are still doing it for meniscal tears, which is really just a part of arthritis. And again, there's high certainty evidence that it doesn't work for that either in most cases. So the evidence, and I can't remember where I found this slide, but this is a slide I talk about when I talk about the new standards for osteoarthritis in Australia. The evidence now, we have many placebo-controlled trials showing that arthroscopy makes no difference over placebo. It's probably even provides a smaller benefit than exercise alone. This is our systematic review showing basically that if you have the arthroscopy, your pain score might be 2.4 points out of 100 better than if you don't, which is something that you won't actually be able to feel. So it doesn't benefit you in terms of pain, doesn't benefit you in terms of function, and probably exercise is a little bit better. We had the first trial for this in 2002, but it took many, many years before the surgeons came on board with this, and years and years and years of convincing them. They didn't believe the evidence, and other people would do trials and find the same things. And we eventually did a clinical guideline in 2017 saying that it should no longer be offered. We've also looked at the information that patients get, and unfortunately they still getting really poor information. They're not being told what the evidence is. They're told that it works. They're not really clearly even telling people that there's any controversy about it. And this is hard to read, but the dark blue is public hospitals. So it's like the spine one I showed you before, and the pale line is what happens in private. And I put this up to show you the difference between down here, the good people, and up here, the bad people. And if you want a knee arthroscopy, you just need to go to Metropolitan Adelaide. That's the centre of knee arthroscopy in Australia, and it's an open secret. That's where they go and just do. My colleague Denise O'Connor, mother-in-law, she could not convince her not to have it. She actually had it made, and now she's complaining it's worse. So if we can't even convince our relatives, that's the problem. So we're actually testing this decision aid, where we're trying to see if we give people these information that actually shows that the evidence is that it doesn't make any doesn't make any difference. Well, will that stop? Will that help to reduce it? And when we were doing this, we were meeting with people who'd had knee arthroscopy or had told they needed it. And after an hour, they didn't get it, they didn't get it, they didn't get it. And then finally, so you mean it really doesn't work? And I'd say, yes, it really doesn't work. And then they were angry. They were so angry that no one had ever told them that. And so I think we're doing a disservice to our patients. This is the trial. We're actually doing a trial of this decision aid. So if anyone's contemplating having a knee arthroscopy, you're welcome to take a photo of that and go into the study. Another surgery that we know doesn't work is decompression of the shoulder. And again, we've done a systematic review. And again, we've done a guideline published in the BMJ saying we should no longer offer this treatment. But this still hasn't reached the ears of some of the shoulder surgeons, but some of them have already stopped doing this. So these are just examples from our research of low-hanging fruit. And I don't have time to go into it, but I wanted to just quickly talk about medicinal cannabis because people seem to be interested in that. This is the number of people that are getting a medicinal cannabis in Australia over time. 61% of it is for chronic pain. They're also, every week, the TGA are finding direct-to-consumer advertising. Every week, there's a new company selling cannabis directly to patients. So what's the evidence? Does it actually work for chronic pain? So the guidelines around the world, including in Australia, is that you shouldn't offer it because there's no strong evidence that it actually works. And if you want to offer it, it should be in a trial. We've actually done a review of the trials, and basically it doesn't work. It doesn't work either for either cancer pain or non-cancer pain, and it has lots of harms. And these are just based on the trials. A fifth of people get dizziness, and then they got all these other effects, and that's not counting the effects that are longer term because these trials were all short. So really, medical cannabis for chronic pain not only doesn't work, but it harms people. And I think this is going to be another epidemic that will take over from opioids around the world. It's already doing that. The other problem that I don't have time to go about is that about overall 1 in 20 things that we do have high certainty evidence that it actually works. So 19 out of 20 of the treatments that we're doing, we either don't know that it works because it hasn't been tested, or it may not work. And so in another talk to researchers, I talk about all the research waste that's happening. We're doing so many useless studies that are not asking the right questions. And so that's another huge problem. So what is high quality evidence? So this is actual data, and I'll tell you where it's from in a minute. But you can see 19 people try a new treatment. Their average pain before is 8 out of 10, and their average pain after is 3 out of 10. So what do you think? Do you think, I'm just seeing how much time I've got. Do you think the treatment works? What do you think? Hands up if you think it looks fantastic. Promising. Hands up if you think you don't know.
Regression to the mean.
Okay, all right. So this is a really common problem. Often the surgeons go, well, I've done the operation, the patient's better. And the problem is that they think that the operation is the reason why the patient's better. But in our field, a lot of things get better over time, irrespective of what you do. And if you've just done something, the last treatment that you've had, that suddenly you're better, you're going to think that that's what fixed you. But in fact, it's a logical fallacy that doesn't hold up. And this is the problem with not understanding the evidence, and personal experience and seeing people improve doesn't actually mean that your treatment is the cause of that. And so the fairest test to test a new treatment is to do a randomized trial where half the people get the real treatment and then the other half get a pretend treatment, and they don't know what treatment they've got. And then at the end of follow-up, you see whether there was actually a real difference. And so that's how knee arthroscopy was found not to work. It was no different from a pretend operation. And so it's important to blind people. So I want to talk to you about vertebroplasty. This is I don't know if you know what vertebroplasty is, but I like this title. So it's the mysterious case of the disappearing effect. And it's really been described as a poster child for this problem of not appropriately evaluating things before we give it to patients. So vertebroplasty, it's for acute spinal fractures. Mostly these occur in older people. They're very painful, but some people don't have symptoms, but they get better quickly. Most people get better by 6 weeks. And so you just treat them supportively with painkillers and bed rest, and it mostly gets better very quickly. Like I've seen it get better. I'll tell you about a case in a minute. So the vertebroplasty is actually some bone cement. So it's cement that you inject into the fracture, and it stays there for life. It hardens. And it was first introduced in the late 1980s, and then it just exploded, particularly in the US and Europe. And that became the normal treatment for fractures. As soon as you had a fracture, you had this treatment. That was despite the fact that there was no randomized evidence. And in fact, what I showed you is from these before-after studies. So we thought we would do a trial of this because it looked promising, but we were worried about the cement, wouldn't that harm what happens if the cement leaked, and what happens to the adjacent vertebrae? Would they be at increased risk because they've got this block of cement? And so, again, the miracle cure, this comes from the Daily Telegraph, the bed bound can walk again, this miracle effect. So we actually did a trial. It was funded by the Australian government, and was published at the same time as a similar trial in the US, not as good as ours, of course. And we found identical things. It didn't work. It actually had no difference over placebo. We had patients who, there was one patient who was flown down from the country because they were in agony, drove himself home. When we finished the trial, I looked up what he had. He had placebo. We had people who were entered into the trial, but then their pain disappeared before we could put them in the trial. And so it didn't work, and people were like stunned. I was stunned until I started to think about it a bit more. And, people had been using this for decades, and it didn't make any difference. And immediately afterwards, the orthopaedic surgeons who were using it stopped it, so the red line. But the blue line is the interventional radiologists, and they just didn't believe it. They know it works because they saw people, get up from being bedbound. And so we did a Cochrane review. There's 3 other trials now. There's 5 trials, all showing the same thing. It doesn't actually work. So the people who didn't like our results tried to do other trials, and they came up with the same results. And not only doesn't it work, it can kill people. That cement can cause paraplegia, which is permanent. There's a patient in Geelong that I was involved in a legal case who had it in her mid-50s. She's now paraplegic. The court case, they settled out of court, as they always do, because they don't want that publicity. It can perforate your heart. It can cause pulmonary emboli. So there's lots of harms, and it doesn't actually work. So when Martin van der Weyden was the editor of the MJA, and at that time, any trial in the New England, he asked to write, the authors were asked to write an article in the MJA about it. So we wrote the article, and then, as he says in his own words, strange things began to happen. He received an email critical of the content of the article that no one else had seen but us. And then people arrived on his doorstep demanding that he not publish this. And then I was, every day I'd get emails that, I should put my head in a microwave oven and die. And it was terrible. It went on. It's still going on, actually. This is an email we published a few years later. We put all the data together. And this is an email I got from someone at the Mayo Clinic who thought that I was a socialist charlatan. I should go and work in Cuba, but I probably wouldn't be allowed to practice. And they wished that we had fractures. So we actually got an apology from the head of the Mayo. He had to write us an apology and said, well, hopefully we can work together one day, right. Who knew that publishing unpopular results could lead to personal attacks? Well, I didn't. I actually knew because it happened to me before. But this is what happens when doctors and industry are tightly involved. And there were lots of systematic efforts. They put editorials in all their journals. The radiologists really went after us, both here and in the US. So the other trialist is a radiologist, so he had a much harder time even than me. And even Wikipedia, they tried to change the evidence. They tried to say that it said it was controversial, and their proposed changes were except for people who know it works. And so luckily there's a custodian who was watching this and then tracked down who was trying to make these changes, and he was a radiologist in the US who gets lots of money from these companies who make the cement. So there's lots of evil things happening in the world. So that's sort of where I want to leave the evidence. And there's lots more examples in the book of things that doctors have done that have been harmful. But we wanted at the end to talk about what can doctors do, what can the government do, what could public health do, and what can patients do. And you know, I think that we need much tougher decisions. We need to not subsidise treatments before they've been evaluated, and we're trying to work on that, but it's really incredibly difficult for the government to change that. We should make sure media reports have, if there's a conflict of interest for the person they're interviewing, that should be disclosed. We came up with Medical Watch, like Media Watch, but it should be Medical Watch, where we could bring it to the attention. But really, it's whack-a-mole. There are so many bad things that you stop one thing and something else comes up. We think health literacy needs to be taught in schools. We need the public to better understand the evidence, and we need clinicians to better understand the evidence. We think patients need to ask their doctors questions, and there's questions like, what would happen if I did nothing? What are the alternatives? What's the evidence that this works? And what are the benefits in the trials? What are the benefits in your hands? What are the risks in your hands? So if they're a surgeon, you want to know what their data is. But you need to force them to tell you what the evidence is. And if they don't know it, then I'd get a second opinion. I think we should all have things in our waiting rooms that says, ask questions of your doctor. We want to answer questions. But the problem is we can't put it on patients, because when you're sick and you go to the doctor, you just want to listen to what the expert says, and it's a really hard thing to do. So that's why we want to focus on changing what clinicians do, because that's the primary purpose of a good doctor, is to actually understand the evidence and help patients make the right decision for their health. We do have part of this group called Wiser Healthcare, which are researchers across Australia that are all involved in trying to reduce this problem. And we have an action statement, but I don't think anyone ever has done anything. It's really hard to action. I just wanted to highlight Ian Harris is the orthopaedic surgeon who I wrote the book with. He's an orthopaedic surgeon, and he's tall and big and doesn't get nearly as much harassed as me, and says it's all my fault. This is Bellagio. We were really lucky to get a Rockefeller Foundation writing residency to write our book. We had 6 weeks in 6 weeks in Bellagio. So that's the town of Bellagio, and everything above that town in green is the Bellagio estate, which used to be owned by the Italian royal family. And then the last person that owned it was an American woman who wanted to do something good and gave it to the Rockefeller Foundation on the provision that something good would happen. So since 1958, they've had writing residencies there. This is where the first HIV conference was, where all the gurus came and talked about what's going on. And my room was just so that this is where the director of the centre lives, and we were in here, and there were some other villas spread throughout. And one of the conditions is that the grounds have to be open to the public every day. And so there's tours of the public and they're told to be quiet around us and we're working hard. So you feel really special and you get these keys and it's all and you just feel like you live in Bellagio. So that was one of the best experiences, I think, that we did. And we wanted to arrive by ferry. So this is us actually arriving. These are some of these amazing people I work with around Australia. And this is some of my team. If you want to read about more, we have podcast. Quite a few people have done podcasts, including the BMJ. That's my email, and that's one of the cartoons I was telling you guys before. Looney gave us this cartoon, and there are other cartoons in the book as well. And I think, that was, again, I was just advertising that. And that's it. Thank you.